well, those of you who were there this morning know that I think it's going to be fun for the next 45 minutes or an hour. The retreat is 2 weeks, and Melanie, where's Melanie? There she is. Melanie has, and the committee have done a very good job about putting together a very good program, and it's going to be a triple threat program. And I think that Anna and Jim, is Jim here? He was upstairs, I don't know. Well, and Neil, spread the word to the VA section too, and I think it's on the radar screen. There's going to be a town meeting with Mark Bell. You're here. You're
remember that one.
You can't leave.
That one is at 8, and you can only stay 30 minutes. So.
All right.
Be there.
So with Mark Bell, who is the chief of operations for the medical group, and he's going to have a town meeting about the new primary care strategy for the medical group. And I think that the VA group will be very interested in listening to this too. That's going to kick things off. Then we're going to have an intense research opportunities briefing that's going to go into what's available now in the CTRI, new research planning things for people interested in doing clinical research. And then we're going to be talking about teaching and a redesign of the way we're teaching in our continuity clinics. And so Simrajot and Stacy are going to join our other clinic chiefs in terms of discussing the residency clinic chiefs, in terms of discussing changes that I think are going to be very interesting to all of us. And this does go across the division for the VA section and the medical group section. So I think there's going to be a number of things that are going to be very interesting to everybody in the group. And do I hear you coming in, Simrajot?
Sorry.
So you got there. Well, that's okay. No, we got our business done. Well, all of you who were upstairs know that we're going to have fun for the next 45 minutes or an hour. And I'm going to let Simrajot carry through with the introductions. And I promise you a lively session.
Good morning. Thank you for coming to GIF Grand Rounds. It's my pleasure to introduce my friend and colleague, Dr. Kirsten Bibbins Domingo. As all of you who are at Grand Rounds already know, she has had a really remarkable and illustrious career as a general internist. She received her bachelor's degree at Princeton University, followed by a master's degree in Nigeria. She then pursued a PhD at UCSF, followed by an MD, internship and residency at UCSF, and a general internal medicine fellowship and a master's degree there. She's now the chair of epidemiology at UCSF, and also a professor of medicine. She's the immediate past chair of the U.S. Preventive Services Task Force. She's a member of the American Society of Clinical Investigation, as well as a member of the National Academy of Science, really amazing distinctions. She's the author on hundreds of top-notch peer-reviewed publications and has a great deal of grant funding from the NIH and other organizations. Her current titles, I don't really know how she does everything that she does, but they include Vice Dean for Population Health and Health Equity, Director of the UCSF Center for Vulnerable Populations at Zuckerberg San Francisco General Hospital, and she's also the Director for the training programs for the Clinical and Translational Science Institute. So please join me in welcoming Dr. Bibbins.
Okay, here's that. Good. So how many people were upstairs at the prior talk? Oh, good. So most people. Okay. All right. So I'm going to assume that I think some of my slides duplicate just a little bit, but we'll zoom through those, and then we'll talk about some of the thornier issues that we have to deal with. So what I would love to talk about is where the rubber meets the road and trying to implement guidelines like this in clinical practice, right? So the issues with clinical practice have to do with a lot of the very issue of us taking information on a population, generating a recommendation for a population, and then all of us as individual physicians trying to apply that to an individual patient, right? And so that's how I've tried to couch some of this talk, and just to look at sort of the application of the individual patient, but and how we've tried to communicate better. How many of you use the task force's recommendations and how you think about these approaches? How many use other, for screening or preventive recommendations, use other guidelines? How do we rate relative to other guidelines for things? You can be honest, I'm not a task force anymore, so. And I'm also a practicing clinician, so. What do you guys think?
Well, I like to look at the actual evidence that's used to develop the guidelines.
Yeah.
See what those articles say and what they seem to demonstrate. And then as I look at the guidelines from, say, American College of Gastroenterology or American College of OB/GYN or American Endocrinology or something like that, I look at how they interpret that same information, and sometimes it's different.
Yeah.
Sometimes those interpretations are different, and so I like to look at both of them and kind of see, what do I think of the evidence? Who made the better argument?
Yeah.
Where are the arguments lacking something?
Yeah, good, yeah.
So I'll engage the patient in that. Because, I mean, you pointed out earlier, spoiler alert,
Yeah.
there are levels of confidence you have, ABC.
Yeah.
And the way that the professional societies couch their recommendations tend to be a little different, and the thought process is different.
Mhm.
And for different screening patients,
Mhm.
the logic appeals differently.
Mhm.
And I think it's a good opportunity for a dialogue, a 90-second dialogue.
Good. 90 seconds, you must be good. Other people? Yeah, so I think that's exactly, I really believe passionately in trying to make science accessible to lots of us who have to then apply it and to use it in conversations with patients. One of the things that I hate about the task force is that people then read the letter grade and stop there. And I have to tell you, remember, we do 12 recommendations a year. We actually spend a lot of time crafting a lot of language for a lot of ways in which things are implemented. We spend a lot of time reading other people's recommendations. And it is my hope in the end that even if you don't like a letter grade or whatever, our hope is that it is clear why we got what our thought process was to get to a particular recommendation. Because if you understand that thought process and then even can figure out how to go to the prior studies, that you can figure out how to apply it, right? If I thought that our goal was just to convince you of like the letter grade, that's sort of ridiculous because, none of this, it's not like, we're the Pope coming down with some infallible body of knowledge, right? We're like just trying to communicate about what the science is, and the most important thing for all of us as practicing clinicians who know how to read the scientific literature is actually to understand where are those critical points in how we think about the science so that we can decide whether it applies to the patient in front of us. So I'm going to talk about, I developed this talk for understanding the diversity of patients in clinical practice, but I think it translates basically into all of the issues that we have in clinical practice, because it has to do with how do you tailor a particular recommendation to that patient that's sitting in front of you. So I've been a member of the task force since 2010, and I chaired the task force last year. We're going to review a little bit. Some of this is repeat, but I'm going to go very quickly through that, and I'm going to discuss our current approaches to how do we write to tailor recommendations. So again, we're an independent panel. We do recommendations for preventive services in clinical practice for people without signs or symptoms of disease. This is our process, which I'm not going to go through. But just to remind you again of the grades, the way we do the grades here is that we're interested in understanding the body of literature, whether we actually have studies, so how certain are we based on those studies, and then we're evaluating net benefit, whether when we evaluate benefits and we evaluate harms and we put them together, whether on average that leads to a net benefit. And remember, this is on average, right? Because all recommendations like this are about a population, right? And so a lot of what we discussed this morning, even in the questions, was it really depends on which population you think is more likely to benefit and those types of things about whether you think that net benefit is going to apply to that given patient. And I think understanding how we come up with a recommendation for the population and what parameters are there that allow us to arrive at net benefit in the ideal world will hopefully help you think about, and all of us think about, how we tailor that to then that patient sitting in front of us. I don't believe guidelines should come up with every possible scenario for everything for a clinician, but I think ideally a guideline comes up with the main pieces that sort of motivate an argument for or against doing something. Right, so our recommendations A, B, and C are recommendations in favor to do. D says don't do it. And I says there's not enough evidence and it's not a recommendation against screening, it's a call for more research. All right, so the task force, one of the goals of the task force, and this has been true for a long time, the task force has been around for 30 years, but it has been particularly true, I would say, for sure during the years that I was on the task force from 2010 up to the present, is that we're working hard to make recommendations useful to all different communities in the US, all different types of practices in the US. We're very interested in how our recommendations would actually be implemented. Why do we have that focus? Well, some of this is equity. So the mission statement of the task force is actually assuring the health of all Americans. So if we are not making recommendations that one could figure out how to apply to a particular population in your practice, then maybe we're not doing our job well, right? We know that there are certain groups that are disproportionately affected by disease, and that if we wanted to improve their health, and that's a goal of our Healthy People 2020, that we actually, screening would be an important part of that. And then finally, relates to the variation. So those of you who do quality and know what high quality care is our goal is to limit unnecessary variation, right? That is why guidelines are made. That is our goal there, is to say, this is on average the best way to approach this. And so if you're really outside the norm of how we think the best way to approach it is. But high quality care also says pay attention to necessary variation, right? And so I think this is the tension for the task force, is that guidelines really are helping us to limit unnecessary variation, but it's harder to figure out how do we communicate that necessary variation. When should you be saying, for sure, this group should start mammography screening at age 40, and this group can probably wait a little bit longer, right? So here's the tension. And this relates to some of the things we were talking about in the question and answer, is how much more incremental evidence do you need to make a recommendation for a particular subgroup, right? One could imagine all different ways in which the patient sitting in front of you differs from the patients that were included in a particular clinical trial. So how much more evidence do you need for that particular subgroup to make a recommendation? I'll give you an example for our screening for abdominal aortic aneurysm, right? So does anyone know our recommendation there? Yeah.
Just for men with former smokers over the age of 86.
Oh my God, I love that. So the data for that is really interesting. So, most of the studies are done in men or former smokers, right? So the question, does that translate to all men, including men who are not former smokers? How does it translate to women who are smokers, right? And so, a lot of what we did with that particular recommendation is you're right that our main recommendation applies there, but we did a lot of trying to extrapolate. When would it be reasonable to extrapolate? So at the extreme, if you're a woman who doesn't smoke, there's probably not a reason to do any screening for abdominal aortic aneurysm. The two groups in the middle are the ones that are hard to figure out, because clearly sex and smoking are like the biggest risk factors. And there we did a lot of looking at the epi data, right? So when women do get abdominal aortic aneurysm, they just get them at a different point in time. So when would you screen? How would you extrapolate? So, but the question is, are we gonna wait until we have studies in women? Are we gonna wait to have studies in non-smokers? How do we extrapolate that? So that's one of the big tensions that we're engaged in. How do we balance the goal of calling for more research in a particular group with the desire to make a recommendation for that group, right? We think that one of our jobs is to say, there's not enough evidence. This is an I statement. Whereas we know that in clinical practice, you have to do something even in the face of no evidence. And sometimes we want to be able to call out when it's reasonable to do this. And then finally, how this is complex. Our recommendations are complex to begin with. How do we communicate this complexity in a way that's useful for patients and useful for clinicians? Right. So, we have been trying to think about how to do this at each stage. We spend a lot of times now engaging stakeholder groups to provide comments at each step. We have really advanced the methodologies of understanding heterogeneity in the evidence review. And I would say the evidence-based practice centers who support the task force, actually, this idea of heterogeneity is another way of saying sort of the variation in the population, right? The patient, how the patient that you're taking care of is different than the average. This is a methods question in addition to being a clinical question, and I think our evidence-based practice centers are actually advancing this methodology quite a bit. And then we spend a lot of time with our communications team trying to communicate on our final products. So I want to talk about, I think, five different ways that we have been, in recent recommendations, have been trying to do this better. I would love to engage in a conversation of how you think we could do it better, because I'm not saying we have it right. I'll also say, how many of you have ever nominated a topic, commented on a topic, or engaged in any way in anything we've done? I would really urge you to do it. I would urge you to do it. You can get the alerts for when things are published. We try to communicate about this a lot. I'll tell you, my colleagues at Zuckerberg San Francisco General Hospital, when we released our lung cancer screening recommendation. So do we know our recommendation for lung cancer screening? So screening smokers with a CT scan, I'm forgetting the ages right now, is our lung cancer screening recommendation. And basically, they said, you are going to bankrupt our system, right? Like, this does not make sense. We cannot screen every single person. You cannot give us that recommendation, right? That's crazy. And they were great. They had great comments. And if you look at our implementation section, a lot of that language reflects the comments that we got from them writing it, basically. Because it was about, okay, let's remember, screening only improves lives if you have a group of people who are going to follow through on all those steps, right, that it takes to do that, right? And then talked about other things that were not grounded at that time. Since then, there's been a lot of evidence published about how to risk stratify a bit better. But a lot of language saying that there are ways to tailor, there are ways that might guide how one implements in clinical practice. I will just say parenthetically, because it relates to that thing, that the task force is allowed to consider cost. In fact, our authorizing language says we should consider cost. We've never considered cost because it's sort of the third rail of American healthcare. Our recommendations end up being controversial enough, even though we don't consider costs. But recommendations like things for cancer screening, which, for any given system, and our system was the trade-off between our smoking cessation programs and screening for lung cancer, that is a very real trade-off that we know, but is not something we can address in the way we're currently configured. So let me get to now sort of communicating about the heterogeneity of the population. So a first area we've spent a lot of time doing, trying to think about how to do this, is communicating who is at risk, right? So here's the recommendation for latent TB screening. The task force recommends screening for latent TB in populations at increased risk. And here's our recommendation for syphilis screening in non-pregnant adults and adolescents. recommends screening for syphilis in persons who are at increased risk. We spend a lot of time, so that's how the top line reads, and our hope is then you will read the next few paragraphs, and I would definitely urge all of you, no matter what the recommendation is to read the next few paragraphs. A question is here, how do you communicate who is at increased risk? And this is where we write these, what end up being very dense paragraphs, but are paragraphs that are meant to try to help a person sitting within a different practice environment from another person decide who is at risk in your population, right? So this is the way the screening recommendation reads for syphilis. We had some suggestions early on to write a recommendation that says, we should say men who have sex with men, right? That's who we want to screen. We had other recommendation, people who said we should write this for African Americans who are at increased risk. The problem is, if you look at the practice patterns for syphilis in the US and who's getting syphilis, it relates really to the clusters of people who are essentially having sex with people who are at risk for syphilis, right? And that relates to demographic factors like race, ethnicity. It relates to sexual practices. It relates to other aspects of the community, but it also relates to the baseline prevalence of syphilis in that community, right? So making a recommendation that says you should screen Black people for syphilis is not a good way to make a recommendation, even though others have made recommendations that way. Making recommendations that say you should screen men who have sex with men, which then sounds like that's exclusively who you should screen, is also probably not the right way to do it. So that's why we spend a lot of time writing this very wordy paragraph to try to give you a sense of that. We did want to call out men who have sex with men and men and women living with HIV because they are clearly at highest risk, right? It's both the communities who are having sex as well as the fact that HIV puts you at higher risk for syphilis infection. And we wanted to call it out because if you look at all of the cases of syphilis, like that group makes up a disproportionate number of them, right? So then you say you want to understand the prevalence of infection in the communities that you serve. So men, of course, and young men, regardless of these other factors, actually account for most of the cases. And then you want to understand the practice patterns of where you are, which part of the country, and which particular race, ethnic, demographic, and other things. Those are important. But this is complex information, and what we're often trying to say is, you need to know the baseline prevalence in your community, because in some communities that have such a high prevalence, while this may be true, you want to be screening the women in those communities, right? Obviously because of the way that the practice patterns are. And so I don't know whether this is the right way to do it, but it is the way we have chosen to embed lots of other much more specific information into our recommendation statement beyond the first line. If you look at our screening for latent TB, we've done a very similar thing. In the end, people asked us to call out immigrants. They asked us to call out other factors, which are called out in here, but we call that in a way that you don't shortcut into a particular race, ethnic group, or a particular whatever, where it really is about the manner in which you're exposed to the things that put you at risk here. Yes?
Before you leave that, so this is the issues with it. How have groups like maybe Group Health or Kaiser, have they taken positions on this particular one, or in terms of how do they just ignore it? Do they recommend consideration, or do they set up a program to organize screening around this and syphilis?
I don't actually know I don't know the specific answers to that. I think when I've worked with Kaiser on other things, they actually are pretty good at setting up, taking the language here and figuring out within our practice patterns and the patterns of disease in our population what we would recommend. And that's the intent here, is to give you language to say, okay, based on where you are, what's the best approach to doing this? You see what I mean? How everyone does it, I don't know. But I know that many health systems, when I go to Dartmouth, that's what they talk about, how they tailor, and I think that that's what it is. This contrasts with recommendations that we have like universal screening. So HIV is a universal screening recommendation, right? It says, don't think about it, don't think about risk. This is a universal screening recommendation because the screening studies for HIV make it very clear that you shouldn't be thinking about because for many things, we know doctors are not very good at assessing risk, so. Okay. So, the second area I want to discuss is balancing the call for more research with providing clinicians useful information for their clinical practice. So here, this is the screening for abnormal blood glucose for type 2 diabetes. And so the recommendation here for the task force is that we recommend screening for abnormal blood glucose as a part of cardiovascular risk assessment in adults ages 40 to 70 who are overweight or obese. Clinicians should offer or refer patients with a normal blood glucose like your patient who has, polyuria, polydipsia, symptomatic. We're talking about sending a blood glucose in somebody who has nothing, right? This recommendation is based it's basically based on the lifestyle interventions in like the DPPs type studies that healthy diet, physical activity in people who have an abnormal blood glucose can actually delay, prevent type 2 diabetes and therefore the consequences, right? That's the rationale here. So these studies are done, so these apply to adults ages 40 to 70. The problem is, of course, if you look in the US and you say, who's developing type 2 diabetes, it is happening disproportionately in many poor and minority populations. And some of these minority populations are at increased risk for diabetes at younger ages than what we specify and at BMIs lower than what we specify, right? But we have no data in those particular populations. And so the question is how to communicate the fact that, you might want to consider screening in these higher risk groups outside of the bounds of our particular guidelines for our recommendation. And these groups actually have higher risk, and that itself should be a reason we would consider screening, right? So this is how, again, we chose to do this. This doesn't appear in the top line of the recommendation, it appears under it, but it points out the groups that are at higher risk and that they might be at higher risk at other factors, lower age, lower body mass index than what we call out in our top line. We want to always make sure that we describe here that the studies here were only done in Europe, and therefore we want more evidence in race ethnic minority populations who are at higher risk so that we can tailor, because that's important as well. When we went to so I spent a lot of time talking to colleagues who are very active in the Asian Pacific Islander diabetes advocacy community. They really wanted more information, more clinicians to be aware, particularly the risk among Asian Americans of diabetes risk at lower body mass index. So what we did, we had this language in here already, and we decided if you go to our website, we put this language. It's not in the top line, but it's featured prominently on our website so that we have it there. And it's actually a good lesson for me was the importance of interacting with advocacy communities, because we didn't actually change what we did or our processes. We were always going to put this language there, but by pointing it out to them, they were able to do much more advocacy around what different health systems decide to do. And if you listen to a lot of my colleagues who work in diabetes, they basically have used this language to basically advocate for sort of loosening many of the very strict criteria outlined here when you're talking about patients here. This is a particular recommendation, although again, we don't make recommendations for coverage, that was interpreted by many as covering interventions like the DPP style interventions. And I think that for many that is perceived as increasing access to those types of services. The third thing that I want to just highlight is reminding people that important disparities may not necessarily be alleviated by increased screening. And the reason I highlight this is because one of my pet peeves in the way criticism comes to the task force is when people co-opt the sort of disparities argument in order to criticize the recommendation of the task force. And so, we talked about breast cancer screening recommendations earlier. So our recommendation for women ages 50 to 74 to get screened every other year, and that to consider screening, women in their 40s should consider screening as long as they understand the risks and benefits. There are net benefits, but those benefits are smaller than they are for older women. I showed this earlier. This was some of the campaign that was launched against these recommendations. And included this particular woman. It's not an accident that this is an African-American woman, because it was the way in which a lot of this criticism of the task force was mobilized. Because African-Americans are more likely to die of breast cancer than white women, which is a very important point. The reason for the disparity is not entirely clear. It might be biology, because African-American women are more likely to develop triple-negative phenotypes. It's also clear that African-American women are more likely to have delays in receiving preventive services or lack treatment altogether. African-American women are severely underrepresented in the clinical trials. The largest trials were performed in Europe, and the direct evidence in this population is sort of lacking and represents a critical need. So the question is, how do we communicate the importance of this group, and the importance of understanding breast cancer risk in this group in the face of limited evidence, and also in the face of others trying to co-opt this particular concern about African-American women as a way to criticize the overall recommendation. And here, the crucial tension here is this for us. So if you look at the very important issue of breast cancer in African-American women, that disparity in mortality is likely not related to screening. So incidence here is, and between blacks and whites, is really a marker for who's getting screened, because that's how we detect things. And what you can see here is that black women and white women are diagnosed with cancer, breast cancer, at about the same rate. We have increased screening for everyone between 75 and 2012. That's why all these numbers are going up, incidence rates are going up. That is directly related to screening. And there is no gap between our screening rates, detection rates, between blacks and whites. But the problem that we need to solve is this problem here, the big gap between blacks and whites in terms of mortality rates, where you've seen one go down and one go down at a much, that not going down quite as quickly. And the concern for me is so I have two concerns. One is I want to communicate to African-American women and to clinicians who care for them about their increased risk of breast cancer, and that's important. But letting the screening for breast cancer be the entire discussion or overwhelm the discussion, which really needs to focus on this, is potentially problematic. And in fact, I think potentially harmful. Yes?
So, I'm sorry, I just wanted to clarify. So you said something about that, obviously the incidence is going up, and you said it's related to screening.
Yeah, so the incidence is going up not because there actually is more breast cancer, we're just detecting more breast cancer. That's what's true about screening.
Okay, so if you were to superimpose the incidence curves with BMI, what would you find?
I don't know.
Because people are getting more obese.
Yeah, people are getting more obese. That is also true. I think, I don't have the right slide here, I have it as a part of the other talk. It's remarkable if you superimpose just the 5 years, 5 to 10 years where we started, really concerted effort at mammography screening. That's where the diagnoses go up. Sure, it might be also true that there are other secular trends that are really related to the biology.
And that some of this
So we
is,
know that obesity and breast cancer are related, we know that.
Yeah.
And so, you know, the relationship, the cause effect is not clear.
Yeah.
And so I wouldn't want the whole discussion to be about just mammography, I would also want it to be about obesity discussions and risk factor modifications.
absolutely, absolutely. I'm not meaning to say that there might not be more breast cancer. I'm not meaning to say that at all. And I am very willing to say that that some of the increase in incidence may be related to other secular trends like obesity, but some is also related to detection, right? We're just detecting more. We're just detecting more. If you look at, this has gone up 50%. It is very unlikely in this time course that obesity explains 50%.
Well, if you look at the curves of obesity since the 70s, they're really quite remarkable,
Yeah, I agree. I totally agree.
especially in certain demographics. So I guess I would like to see more information in order to give people a definite recommendation about attribution.
Okay, right. So I agree with you, and maybe I am making too fine a point of this because I'm absolutely not recommending against breast cancer screening. I definitely agree with you that there are other secular trends, both in environmental exposures and obesity, that relate to diabetes, to breast cancer risk. And in fact, we talk about many of those things, including obesity, in our recommendation. All I'm saying is that the large increases in screening, the large increases in diagnosis of breast cancer, the fact that we do mammography and count many things as breast cancer is at least part of this story, right?
And also with them saying that DCIS is almost pre-cancer, we almost have to reclassify it in retrospect.
Yeah, absolutely.
So a lot of our data is going to be difficult to interpret in retrospect.
Yeah, we actually take DCIS out of this. We actually include mostly, but we do include many things that are diagnosed as cancerous that end up not causing problems for women during their life. The obesity thing is absolutely a risk. It is absolutely an area. That's why we have 3 recommendations on screening for obesity and intervening for obesity, just for that reason. So my point here is not to belabor this point. My point is to say that this gap that we want to do, I want to make sure that we're focused on all the ways that we do that. And screening is actually an essential part of how we prevent mortality from breast cancer. But closing the gap between blacks and whites is probably related to many, many other things other than just making sure African American women get mammography every 2 years, right? So the fourth point I want to make here that we spent a lot of time talking about is that some disparities will absolutely be addressed by increased screening. And one of the most important things here, this is a topic that is currently open for public comment, is our recommendation for cervical cancer screening. This is our old recommendation. We just had a draft paper come out. Cervical cancer screening has had an A recommendation for quite a number of cycles within the task force, and is again in our new updated draft recommendation. Remember, under the Affordable Care Act, although that's not something the task force sought or tried to get linked to, the intent of the Affordable Care Act was actually to increase access to preventive services. And one of the things that we know in cervical cancer is that it is the lack of screening in cervical cancer that is actually a major contributor to the types of race ethnic disparities that we see in terms of incidence. We just have underscreening in many high-risk groups here. It made it clear to me when we went and actually talked to an American Indian advocacy group, because they said to us, we're not sure that your recommendation applies to our group. And it was one of those things where much of the literature really sort of reinforces the underscreening that's happening in American Indian and Alaska Native populations. And so how do we communicate that even if we're studies that are done that don't include American Indian and Alaska Natives in a large number absolutely apply to these populations for something that is very clear has a benefit in terms of preventing mortality from cervical cancer. And then the last thing I would like to just point out is sometimes we dismiss things like the call for more research, that it's something that we tack on at the end of our papers and is sort of a throwaway line. I want to argue that the call for more research is important, and the fact that the task force oftentimes defaults to an I is actually can be or should be mobilized for many groups as a good thing. So we make reports to Congress every year about how we can improve the health of the population through clinical preventive services, and we highlight here high priority evidence gaps. This is a report where we highlighted improving the health of women through research. And we actually look over our portfolio and say, these are areas where we couldn't arrive at a recommendation because we didn't have enough research in this area, and this is an area of critical need that we think more funding should be directed towards. One area where we were able to do that was related to screening for intimate partner violence. So in 2004, we made a recommendation that basically was an I. We said there's no direct evidence that screening for family or intimate partner violence leads to decreased disability or premature death. Many people were really horrified that we would come out with an I for a compelling topic like this, but remember, we're making recommendations for screening, that is somebody who doesn't come in with any signs or symptoms, and that to routinely sort of ask about intimate partner violence, was there evidence that doing this would actually improve morbidity and mortality? So we came out with an I. We could not determine the benefits and harms of screening. This actually became a priority area at the NIH and actually within the Canadian research community. And when we updated this recommendation in 2013, this recommendation is now changed. So this is a B recommendation because as a result of some trials, but more observational studies and pragmatic trials, the task force recommends that clinicians screen women of childbearing age for intimate partner violence, such as domestic violence, and provide or refer women who screen positive for intervention services. We still have an I for other groups because we couldn't extrapolate to other groups for whom this might actually be a reasonable practice. But it is an example of where we called out an I, where the I led to more evidence, and now we can, with much more confidence, say that this is actually something that you shouldn't think about you thinking you know who's at high risk. This is something you should be doing routinely in all women in this age group because we know from many high quality studies that this actually improves morbidity and mortality. So in conclusion, reminding you again that we're an independent entity that uses structured systematic review of the scientific evidence to make recommendations for primary care practice. We want to make sure our recommendations are tailored to addressing the needs of all populations in the US, particularly those disproportionately affected by disease. But this is, hopefully you see, also a complex issue, and we're not always doing this perfectly, and so we want to hear from you about how we can do this better. I urge you to stay engaged in our processes, to give us public comments, to stay engaged in how we do this, either individually or through your professional organizations or as your own institution. We really value and utilize individuals from input from individuals and organized stakeholders throughout our process, and it's actually critically important to the work that we're doing. Thank you very much. Happy to take questions.
So I've got a question relevant to your last one. So what are you doing about incorporating, kind of common genetic information into this? Is this really on the horizon, and do you think it's still too early for prime time?
Yeah, it's a super good question. So I appreciated the comment in Grand Rounds. Somebody asked, this is the wave of the future, and in some ways that is absolutely true. The question is, how do you incorporate that type of information, right? I don't want to make a recommendation that everyone should go out and get genetic testing until I know that even that recommendation is going to improve their outcomes, right? So now the question is, so we have a recommendation for BRCA, right? That's a very clear one. That's a very clear one of understanding who in your primary care practice you should refer for additional counseling and screening for BRCA. We do make recommendations, not now for BRCA, but within mammography, as I said earlier, that for women in their 40s who have a mother, sister, or daughter with breast cancer, that they are the ones within that 40 group that should actually think about screening early because of that high risk. But then the question is like, well, what else? So is studies showing that, these set of markers increase your risk of breast cancer by, I don't know, odds ratio of 1.2, 1.3? Is that enough for me to say, oh, you should get that type of test? How would we know when to take genetic information, integrate it with other types of RCT information? Would we have to see a new screening trial of mammography of women who have a certain genotype before we say, oh, that genotype puts you at, the task force needs to sort of believe two things. Not only that you're at higher risk, but that screening actually modifies that risk. And that's where we're always in a little bit of the song and dance. We had this debate when it came up with familial hypercholesterolemia, people who have very high lipids, right? So we had a standard screening practice, but the question was, so this is clearly a high-risk group, but we didn't have enough information from the literature of understanding whether that meant we should start screening them earlier because intervening would actually accomplish its goal. But I think as a task, if we want to remain useful to clinicians, we have to increasingly be able to understand how to incorporate varying lines of evidence. Although RCTs are our highest standard, we can't wait for new trials of people who have like 5 different genetic markers in order to start incorporating that. So we're going to have to do something, but that's where we are.
Well, you had that very nice process slide and you ran rounds talk that showed the branch points. I'm just wondering, is genetic testing now kind of emerging as something that your
we will definitely
analyses will look at automatically?
We will definitely look at it, but I guess knowing that puts you at slightly increased risk and translating that to a different recommendation, that would be the hard part. Do you see what I mean?
Yeah, thank you.
Yeah.
One of the things that I think is really important is to kind of educate groups of people before screening is undertaken. And I know an example that really had very unfortunate consequences. My mother taught elementary school in Detroit for many years, and they decided, it was decades ago, this was a large African-American population, to screen for sickle cell disease.
Yeah.
And they found, a lot of the parents were willing to do it, but when the kids with like the sickle cell trait were detected, then parents didn't want their kids to play with those kids with the notion it was contagious.
Yeah.
As they got older, if you have sickle cell trait, maybe I don't want you to date with those sort of people. And I think when you take groups of, it was well-meaning, kind of pick up people with sickle cell disease, but it's so important to educate populations in terms of the implications of the results before you kind of decide from a public health point of view to apply that. So I think that's just a comment that I want to make. One other question I had is your public health responsibility, for example, with infectious diseases, in terms of encouraging screening when the disease for the individual is untreatable. And I know, like, being of a generation when HIV was basically treatment was very poor. But from a public health point of view, it was important to screen, even if we couldn't benefit an individual patient, and kind of how you deal with issues like that.
So 2 good questions. So let me just say briefly that, so I absolutely agree with you in terms of understanding the implications of screening. We think a lot about that, right? So we think a lot about stigma or other unintended consequences of giving someone a label that happens when you do screening. And so if you read the language of our recommendation, again, a screening test never saved anybody's life, right? A screening test is only about getting you into the things that are the treatments, the other approaches, whatever it is that's going to help prolong your life or improve your morbidity or quality of life. And so, that those stigma and all of those other things are very real harms that we think about, and especially if they're not mitigated by something else that is a benefit. So we talk about that a lot in the way the next layer, the next thing that happens after the screening should get unrolled, the way we talk about it, and hopefully if there's literature. So I totally agree with you, and I think it is sort of it's an implementation challenge. It is also why we don't want to write recommendations that say screen African Americans for syphilis, even though if you look, African Americans have a higher risk of syphilis, right? We don't want to say that because it's not sort of related to all the complexities about risk for syphilis in that population, and we want to be able to talk about it in a way that people understand the behaviors and the types of community patterns that are related to risk, but not the demographic factor that's related to risk. The second area you talk about, so what's our public health? So yeah, so that's a really interesting question. So if you think about the way our logic framework works, we think about risks and benefits only as they apply to the individual. For some recommendations, we want to understand whether there are risks and benefits that happen to other people that we need to also think about. And especially it relates to the infectious diseases, right? Where understanding this might actually result in a change in the likelihood of someone else being affected. Another example where we want to consider somebody else's benefit we had with like screening for cognitive impairment, right? So screening for cognitive impairment might help that individual, but it might be important for the caregivers planning for how to take care of the individual, for example, right? And so we've had a lot of thought of like, how do we understand benefits that accrue to someone other than the person who's being screened, right? It's a little bit of a challenging literature to do that. It's a little bit challenging finding studies. It's also a little bit challenging to say, well, how important is that I want to benefit the caregiver, right? Or is the most important benefit when it comes to the individual? For infectious diseases, we actually do look at whether there's changes, whether a particular screening practice has been shown to result in changes in transmission. That is actually a factor that we explicitly consider. And in other recommendations, we're trying to understand how we consider benefits to people other than the individual being screened.
Dr. Jennings.